Good afternoon, everyone. I'm Umesh Rustogi. I lead the product and engineering teams that build the Dragon Copilot for nurses at Microsoft. And joining here with me is Darren.
Hello, Darren Batara, Manager for Nursing Innovation and Informatics. I'm from Stanford Healthcare.
So Darren and I, together in this session, are basically going to walk you through what are some of the new AI capabilities in Dragon Copilot and how they empower nurses to essentially restore the human connection in patient care. So in terms of an agenda, we'll kind of break it into two parts. I'll start off and take 15 minutes or so walking us through what's Dragon Copilot, what's the specific challenges that's facing the nursing workforce, and what are the AI capabilities to address the same. And then we'll have Darren kind of walk us through the journey that Stanford went through as part of the preview and what kind of learnings they had, what is the user feedback, and what kind of business outcome they basically achieved. And then we'll wrap it up with some kind of next steps, and then over the last maybe 10 minutes or so, we'll love to take questions from you. Thank you, Darren. So for those of you who don't know, Dragon Copilot is an AI clinical assistant for the care teams. It brings together the proven natural language speech capabilities targeted for healthcare, together with the clinical ambient listening capabilities, and infuses that with advanced AI to do a couple of different things. It can help clinicians streamline documentation. For example, a physician using the clinical conversation with the patient to automatically draft clinical notes. It can surface information by searching medical information from a variety of credible and trusted sources like the CDC or the FDA and so on. Or it can automate tasks, for example, creating a narrative note. So these are the different things that the Dragon Copilot does. And Dragon Copilot is also extensible, right? We recently announced how the third-party ecosystem products can basically surface their AI insights back into the clinician's workflow within Dragon Copilot. And Dragon Copilot, as I said, is for various roles within the care team. It has been very extensively used for the last number of years for its ambient listening capabilities by physicians, typically in an ambulatory or a outpatient setting, and this has been done for years. And then clinicians will use this to draft the clinical notes from the conversation with the patient. And Seth Hain from Epic this morning in the keynotes, for those of you who were there, talked about how DAX Copilot or Dragon Copilot has been used by a number of Epic customers to do the same. And to date, we have about 6 million plus encounters that have been documented using these capabilities. And I am now very excited to say that, okay, we are taking the same foundation, same platform, and then expanding its capabilities to the other members of the care team, specifically the nurses in an inpatient and acute care setting. But first, a little bit more about the administrative demands on nurses, right? Most people know that nurses are the backbone of healthcare. However, not very many people realize the profound challenges that these nurses and the nursing workforce faces. In the United States alone, we have about a shortage of 78,000 registered nurses at this point of time. And this number is only expected to increase over a period of time, and it's driven both because of increase in healthcare demand, because of an aging population, as an example, and also because of the attrition or turnover within the nursing workforce over a period of time. So this gap that I alluded to will increase to about 500,000 by 2030. And a big contributor to that is the documentation and the administrative burden that these nurses have to face. So it's said about 2/3 of the nurses today, right, report a high amount of cognitive burden and stress and burnout. And a large part of this is the documentation that they have to do. And one classic example of this in an acute care setting is the flow sheet documentation. where the nurse, as they are visiting the patients, they are visiting them by the bedside and doing various kind of assessments, everything from simple assessments like vitals and pain assessment to something very extensive like a head-to-toe assessment. After they have seen the patient, they basically have to go back into the EHR system and then key in all those tens or hundreds of rows of structured observation that they have made about the patient. And all that obviously creates a high cognitive load for the nurses, and it takes the time away from patient care. It also creates a problem of missed and late documentation, because obviously the nurses, as they are visiting the patient, they are sometimes scribbling the observations on a piece of paper. Sometimes they are, it's said that sometimes they will scribble it on their arm so that they can go back to the workstation and then key it in, right? All this results in missed and late documentation. There's obviously, because of the efficiency issues, you have the problem of nurses having to do incremental overtime and on, right? So all these workflow challenges that exist today because of this documentation and the administrative task essentially lead to all these consequences of the burnout, cognitive load, missed and late documentation, and at the end, time away from patient care. So what we have done with Dragon Copilot is now extended these capabilities, purpose-built for nurses. With Dragon Copilot experiences for nurses, nurses can now use the Epic Rover mobile app with Dragon Copilot embedded inside, and they select the patient. They can now have the conversation with the patient by the bedside, and from that conversation, the AI automatically extracts the structured flow sheet information. You can also have the nurse kind of do a voice memo, or sometimes we like to call it a monologue conversation on the go as they are between patients and in a natural language, and all that is used by AI to extract the structured flow sheet information back and file back in the EHR. The nurse can then review this information back in the EHR system, confirm it, edit if needed, and then file it. What we have also done, and we are announcing this in preview, is additional capabilities in Dragon Copilot app as a side rail to the EHR information, where they could do additional AI actions and insights on top of the same ambient data. From the same recording, or the same transcripts, the nurses can extract now the narrative note, right, that they could use to file in the EHR system. They can create an incident note. They can create a provider notification. From the same transcript, they can now do a query against the transcript, right? They can summarize the interaction that they had with the patient and then figure out all the follow-up items so that they don't have to remember all these things, and then essentially reducing the cognitive load, right? We also have information assist, using which the nurses can now search for all the medical information that they need through credible external sources like CDC, Medline, Walter Kluwer, and so on, and then get that information quickly in one single place with the right safeguards in place. This is something that today they basically use Google search or ChatGPT to get, but don't have those safeguards built in. But we got here through our co-innovation work with 10 of the leading healthcare organizations in the industry. The Dragon Copilot experience for nurses, this was defined through a collaboration with all these organizations and nurses at these organizations. We had about 1,200 plus nurses who participated in this pilot and then gave us very valuable feedback over a period of time. And then we have about 800 plus observations that have already been successfully captured with AI through this system and through these users and at these customers. And now we believe we are ready to launch this solution in general availability on December 1st of this year. But I wanted to talk about how we built this, right? So we had Dragon Copilot, which was extensively used by physicians, but early on we figured out that what the nurses need is something different. There are significant differences between the workflows of nurses versus the physician. I mean, nurses are typically always on the go. It's a very fast-paced environment. The introduction of the mobile processes for them was something new. So what we did over a period of time through this co-innovation experience is got feedback from these 1,200 nurses that I alluded to, and then did innovation and improvement and iteration along these 4 dimensions. First and foremost was improving the AI accuracy and building that trust, right? So obviously, if the accuracy of AI is not good enough, we would not have the proper adoption of the system, right? The nurses would have to spend a lot more time editing the feedback. So this is the number 1 thing that we worked on, and this required us to build specific models, AI models, specific fine-tuning for nursing specifically. The second thing that we worked on was enabling the customers for scale. And what I mean by that is nursing workforce is pretty large. We're talking about number of nursing units, thousands of nurses, and so on. And there are specific differences across healthcare organizations when it comes to, for example, flow sheet schemas, right? So every organization has customized their own. So we wanted to give these capabilities to these organizations so that they can do the needed AI customization for their respective schema and then manage the rollout to these large organizations. This also included capabilities like analytics so that they know what is the current adoption level and then how can they drive more adoption within that workforce. The third was expanding the value proposition of the solution itself. When we started, we were doing some basic assessments, the vitals, the pain assessments, and so on, head-to-toe assessment. And then we expanded that to include the LDA assessments, and then the LDA addition and removal, right? And lately, we kind of further expanded this by introducing these additional AI actions and AI insights that I just talked about, whether it's to create a narrative note, to create the provider notification, summarize the interaction, and so on. And then last was, of course, the usability. And this was super important because we had to make sure that we are creating the most friction-free usage of the solution, right, as to how nurse interacts with this. Of course, this required optimal design of the mobile applications. And as we look at the future, we are working actively with various smart hospital room vendors or different wearable device vendors and so on to say, how can we create that integration so that this ambient signal can be captured even without requiring a mobile phone in between. So these are some of the capabilities that we worked on to make sure that the solution that we are building and delivering to the market is actually ready for mass consumption. And what I wanted to do now was play a short video, a very short video that gives a glimpse of what these capabilities are all about.
Introducing a new Dragon Copilot experience, purpose-built for nurses. It's the AI clinical assistant you already know, with new capabilities tailored to the nursing workforce. It simplifies documentation by combining natural language speech and ambient listening with advanced AI to capture care as it happens through supported EHR mobile apps for flowsheet documentation and beyond, and via desktop, where nurses can complete routine tasks with AI. Capture flowsheet documentation ambiently and query patient transcripts. Access trusted medical information in workflow. And draft nurse notes and summarize the prior patient interaction. The result? More meaningful nurse-patient interactions, reduced burnout, stronger care team collaboration, and an experience where nurses feel empowered to care with confidence.
And with that, I actually wanted to invite Darren back. So Stanford Healthcare and Darren have been closely working with Microsoft over the preview period to try out this technology, give us that valuable feedback, and then go through this journey. And then would love for Darren to share what the journey has been like and what the user feedback and business outcomes have been.
Thank you, Umesh. Hi all again. I'm Darren Batara, Manager for Nursing Innovation and Informatics at Stanford. I'm very excited to be here. It's my first time being at a real tech conference. I usually do this in front of healthcare audiences, so I'm happy to really share this to different audiences here. So I want to start by contextualizing, before we talk about this as an ambient IA solution, how we got here, and just to provide some of the background about healthcare in general. When we think about the electronic healthcare record, how we got there, this has probably been in the works for 20 to 30 years. Before that, nurses and most clinicians have been documenting on paper for 50. And so when you think about and think how we actually got to a state of using an electronic health record, it wasn't a like-for-like solution. Part of what came after that was that there was a lot of regulatory agency that came into the market that forced hospitals, because of Medicare Acts, to be able to put and draw reports and produce more analytics. And with that, really, I think, was a defining moment for most of healthcare, because it stewarded us all into this new way of thinking about how we do documentation. And what you see on the screen there also is just now the implementation of other technologies. I mean, technology is pretty ubiquitous within a hospital setting, and I'll show you some images later. But when you think about what's actually happening now at the forefront of most hospitals and healthcare organizations, we are embedding technology in every space that we possibly can. And what is typically used by nurses in everyday work are mobile phones, and we're starting to begin to put a lot of infrastructure into the healthcare design systems of new hospital systems, new urgent care centers, new ambulatory sites, and that is likely going to be the future. And when I think about the long-term vision of AI evolution, I can only imagine that as we start to do this, we saturate the environment. And if you've ever been a patient in a hospital, you know what that's like. It's not very pleasant to begin where no one really wants to be there. But I will say that what happens is the nurses, for the most part, play a pretty translational role in helping patients understand what is actually happening, while also trying to navigate through a number of these tools. We had done a survey. I sit on a shared governance model with the Research Innovation Council, which is comprised of about 60 nurses. And we surveyed them on a number of questions related to electronic healthcare documentation. And so the first question was, how would you rate your satisfaction with the current state of EHR documentation? Most respondents said that they were somewhat dissatisfied, really dissatisfied, or neutral about it. And then when you look to the right, the second question was, how likely would you be to use a speech recognition technology for EHR documentation purposes? And overwhelmingly, most of the respondents felt that they were in favor of doing so. And a lot of them came back with the question of like how and where. And so I bring this picture up to just articulate, just for those of you guys maybe haven't seen how the Dragon application is being used. On the left is the outpatient setting, where the physicians are using this predominantly for primary care visits. So this is typically a physician with a patient for 30 minutes. They go through a notification process. They tell the patient that they're going to be using this new tool to help them record and help with their documentation. And then it's a very clean sort of intersection and experience, both for the patient and for the provider. But then when you thrust the ambient technology into the practice environment of a hospital, and this is for exaggerative purposes here, but that's an intensive care unit, you can see the amount of modalities that are inside of the room there. There are ventilators, there are ECMO pumps, there are dialysis machines, IVs, and all of these things are running at full scale. So when you think about what the nurses are having to do, is they have to stack a lot of this cognition that's happening. So while they're caring for the patient, they're also troubleshooting things, and then on top of that, they're also doing documentation. So you can imagine I might have a change in the patient's ventilating status, so I might need to go there and document that, and then maybe there's a change in the IV pump, I then need to go and document that. So it's very laborious. And I say that just because when you think about the value proposition then, and what really needs to come for these technologies for us, I ask this basic question, which is there a different way that nursing can document into the EHR? And the two value propositions that Umesh spoke to are very consistent here. Real-time documentation results in real-time care. And one of the things that we know about is because of the interruptions, because of the troubleshooting that happens in rooms, it's not uncommon for documentation to be delayed. That can lead to a number of different downstream consequences where maybe the provider who is depending on that information to do something with it doesn't see it. And so how do we leverage this technology then to be able to get that into the system faster for viewability to others? And then from a satisfaction perspective, again, if you've ever been a patient, I'm sure if you've ever sat in a bed and watched in a busy hospital, it's very frustrating because you don't know what's going on. There's a lot of cognition that's happening and a lot of providers and care team members that are coming into the room. And when we think about having to stack all of those administrative functions, the patients don't get that, and so then the nurses don't feel like they're connecting with the patients. And that is really why people go into the profession. They're really going into healthcare to really help people, not to document. No one really says, I want to do this for part of my job. When we think about how we can get to a place of taking a technology like this that is new, innovative, how do we actually put that into a system of a live practice environment? And I put this as a visual just as a reminder to anyone who else might be going on this journey. Getting to a state of pilot requires a lot of preparation and intention. And one of the things that you'll see in this diagram here, this is a pretty small number of things, but probably the highest of priorities that we have to think about when we're putting this into the environment. So we know what the problem statement is. Most nurses in a 12-hour span can spend upwards of 3 to 4 hours of a 12-hour shift just into the electronic health record. That's documenting, maybe doing some chart inquiry, navigating things in the record. That's a pretty large chunk of what's, was otherwise meant to be care for the patients, right? And so when you think about other things that you need to think about before a pilot, planning, making sure that you de-risk the technology, making sure that it works in concert with all of these other things in the room. We've done a fair amount of testing, a fair amount of communications, a lot on training and education. And then what's most important here is that this is a really unique opportunity for Stanford to play a part in a private preview program. And this was, hats off to both Microsoft and our electronic health record partner to steward an experience to let healthcare clinicians actually be in the design process. That never happens. Most of the time we receive these technologies and we adapt to it. So I think going with the feedback piece of it, there's been a lot of engagement with the nurses to be able to be in a pilot and give feedback and iterate on it with the Microsoft partnership. How we also did this is we made sure that whenever you're doing a big change like this, you really have to make sure that you're going with a 360-degree approach here. And so we did a lot of surveys, which you guys just saw. The other thing too, as I was saying, most people, I think now within the healthcare industry are knowing that you need to up your ante on all things AI. So we're doing some things internally at Stanford to raise the bar on AI proficiency, particularly right now centered on prompting. Value and research propositions, there's a lot of studies that will look into the job satisfaction, the reduced cognitive burden, maybe patient satisfaction, so that's underway today. And then IT stakeholder engagement is pretty imperative. For those of you who work in healthcare systems, there's about 50 to 100 people on the back end who are helping us troubleshoot from networking to Wi-Fi to all integrations, HL7, all of those things are constantly rolling, and we have a lot of cadence meetings to make sure that the system is up and running regularly. Umesh talked about a mobile strategy. In today's current version of Dragon Copilot, it's mobile dependent. And I talked to you earlier when I showed you the picture. There will come a time when the camera system in the room will also serve that function. I think right now there's some investigation into how much value we're getting in having a mobile experience to go between rooms, and that is definitely surfaced. But I think longitudinally, it will be important for us to know that a nurse could walk into the room and activate a word and just deliver care while these systems are listening and recording in the background. There's the change management perspective, ongoing testing and rounding. I won't belabor this. This is an image of 4 of our nurses from one of the neuroscience departments at Stanford. None of them had used the mobile application before. None of them have ever dictated live before. And so I put this over here just to cement the process. Like, this is a major change for nurses. We don't typically go and talk out loud. That's something that is really limited to providers in the ambulatory care space, but not something you really see and you vocalize out loud. I would never go out and say, oh, your findings are negative. I would never vocalize that. So we have to be very conscious about the things that we can say and won't say in private. We also had to test a couple of things like microphone fidelity. planning updates, making sure that the ecosystem in the room was up to par. We actually tested inside hospital rooms, so that's one of the neuro AAU departments, and we had to do a lot of testing. We actually had a lot of fun with this, where we had nurses flushing toilets and turning up IV pumps and making sure that the television was blasting loud to make sure that the fidelity of the microphones was actually strong enough to take the technology. And then from a training and education perspective, we did 4-hour training blocks with about 85 nurses, and it was a mix of classroom and hospital room didactic. We incorporated hands-on training, return demonstrations, and then a lot of just interactive workflows. What if I do this? What if there's another patient in the room? What happens if the rounds are coming in? And so we really had to engage the teams to make sure that this technology, there are some parameters of how you use it. You can't just have 50 people in the room. You know, we're a teaching institution. We're in the act of teaching residents and fellows, and so we need to make sure that we are reminding staff that when they're using the technology, they're using it in the right way. And then this was a really big learning for us too, syncing to product enhancements. We have our electronic health record that's constantly undergoing software revisions, and then as the feature enhancements come forth on Microsoft, we need to make sure that we're timing those in a way that allows space for the clinicians to get used to it and to receive those communications. It's really hard when you're doing that with 7,000 people. And then just on to the left, that's an example of some of our of the milestones that we had to target and meet. From an early outcomes perspective, this is probably the most important slide here. This Dragon Copilot reduces nurse documentation latency by 70%. This is actually happening. And for those who are ambient speech users compared to those who are not ambient speech users, there's a pretty significant difference there in the time saved. And again, as I articulated, if I reported that the blood pressure was tanking and I documented that and a physician happened to see that then at the same time, they could then take an intervention on that patient in a faster way. One of the things about hospital systems, we have so many communication bridges and realities that are happening that the communication piece, this really becomes a vector of communication when we don't have the time or the logistics to make those calls. When we hear some of our real-world feedback from some of our nurses, we have a nursing assistant from one of our surgical floors who now depends on this as part of her everyday workflow. And she made a comment that, please don't ever take this away. This is the new way that I work. And then we've had a lot of testimony from nurses that they're much more able to talk freely with their patients because they can set this technology down and just nurse. And I think when we think future state about what that will look like in other modalities outside of a phone, it really opens up the potential and possibilities for bridging that experience with patients again. So next steps, we're looking to scale this. Right now, we're only live at about 85 nurses across 4 departments, and we will be expanding this to over 2,000 nurses within a subset. We have more than that, but we'll do this in sort of phases. And then we want to also look outside of not only nursing, but our ancillary support staff. So you think about physical therapists and respiratory therapists and PTOT, case managers, social workers. There's a lot by role where they could benefit from this type of technology. And with all that, we need to make sure that we put some type of governance and structure because everyone wants it, and we need to be very intentional and gated for how we do that in a way that, that if they do receive the technology, it's working for them. And then all things from analytics, data drives all. As we look to the future around what happens with time and latency, there are other parts of the analytics that we want to look to. If there are corrections, I mean, the technology is not always perfect, and so we are monitoring for hallucinations. We are looking for mapping. Nurses do a different level of documentation than providers do. Providers, and many times get to document into one single flow sheet, but nurses document into these very finite, specific Excel rows. And so the AI has to map exactly to that. And so making sure that our analytics reflect the accuracy of that is a big focus for us. And then again, all things with training and education. And I'm going to bring Umesh back up here.
Thank you, Darren. So what Darren just talked about was Stanford Healthcare's journey. And there were a number of learnings that we had, not just for the product, right, but also for what is the right way to implement or deploy this technology in any healthcare organization so that you actually drive the adoption. So out of all these learnings from Stanford Healthcare and the other organizations that I referred to earlier, I mean, Microsoft actually built these best practices for driving these kind of transformation in any healthcare organization, right? Things like how do you make sure that the nursing unit managers are engaged in these transformation, the nursing leadership is engaged in these transformation. How do you make sure that the right kind of training is done before you roll out the technology? Because as Darren alluded, some of these things are behavior changes. Nurses don't typically like carry the mobile when they are visiting patients. Nurses typically don't have a habit of, not everybody has a habit of caring out loud, right, as they are having these conversations. So all these things are behavior changes, are transformations, and it needs a systemic approach to drive these kind of changes within any organization. So that's something that Microsoft kind of invested in. So take the learnings of all these 10 healthcare organizations as to what is the right way to do the rollouts and what's the right way to manage these deployments, and then package it in some kind of offerings. And this is something that we would be announcing together with the GA in December. So just to wrap it up, just in terms of, okay, hey, what's beyond, right? I mean, what we started with was the capabilities that we have just launched at GA, but thematically, we are looking for an environment where there is a real-time passive information capture, right? Darren just talked about, okay, hey, in hospital rooms, I mean, typically you have gear or equipment where you can capture the audio, you can capture the video, and so on, right? So what if the nurse doesn't actually have to pull out the mobile application and select a patient and do everything or trigger the workflow, but what if she or he just goes about taking care of the patient that they should, and then passively that information gets captured and the works get done, right? We are also looking for responsive intelligence, right, to elevate the nursing practice. And what I mean by that is bringing in intelligence back into the workflow, right? Surface it proactively to the nurse, maybe provide the patient context to the nurse, insights to the nurse, so that she or he can take better care. Also wanted to talk about some of the workflow orchestration possibilities that we have with this solution going forward, right? Using the agentic AI capabilities, we can actually orchestrate the workflow across nursing teams, right, and systems. So a nurse doesn't just interact with the EHR system. Nurse actually does a lot of their day-to-day work in other systems like Microsoft Teams, right? How can we actually, using agentic AI, how can we, and these integrations with Teams and M365, how can we create better workflows for the nurses and then drive all those value proposition? And then, I mean, just to wrap it up, basically have this ambiently powered nursing workflow, right? Which simultaneously integrate all these different aspects, right? The documentation, the task management, the communication, the information retrieval, and so on, right? So that's what we are working towards. And then you'll continue to see more and more of these capabilities as we go about releasing future releases of Dragon Copilot for nurses. So with that, Darren and I would be happy to take questions.
So hi, my wife is a nurse, so everything you said very much resonates with you. Question, we now depend on nurse saying everything so it will get recorded. Sometimes nurse doesn't want to say it for the patient's sake, okay?
Yes.
Number one. The second question, any legal concerns that nurse says something accidentally, it's got recorded, and then somebody picked up on it all, and it's got into the hand of lawyers?
Yeah, very good question. Yeah, very good questions. I think what I had articulated earlier is that I think again, this is all new, and we're doing this in a live practice environment. If a nurse were to report a negative finding for a patient, that's not something that I would ever ask them to verbalize out loud. And so we put those guide rails into during the training. Some of the nurses actually prefer to do the dictation just outside the room. Some of them may even try to whisper it so that the patients don't hear things because maybe the patients are sleeping, not necessarily because they're negative findings. So there's different iterations for how you're leveraging the technology on the go. Our nursing assistants, for example, who work the night shift, there's part of our training for them was to implement, they have to have a lot of like these hands-free things. They're emptying drains, they're ambulating patients down the hallway, and so to be able to keep their hands in there, they've put put the phone upside down into their pocket. We don't totally recommend that, but like every time we learn something new about it, we provide that feedback back to Microsoft. There will be iterations on hardware and how we're capturing that data, but there will also be workflow changes. And I think as Umesh alluded to earlier, yes, there are behavioral changes, but there are workflow changes that I think have been cemented in time. And so when we're really doing this, we're changing the way that people are delivering the care of nursing, but we need to make sure that we're doing that in a way that still preserves the sanctity of the role of the job. And we're one of the most trusted professions for a reason. We don't want to eliminate that by putting a screen in front of us and typing away. So the second question that you gave around the legal aspects, that will differ from institution to institutions. Stanford, I think we are doing our part to make sure that we are having our AI governance look to all things. So whether that results into guidelines or policies and procedures, that journey will look different for every single institution across the board. We are a unionized environment, so we have additional layers that we have to accommodate for, and a lot of that speaks to the training and making sure that we're being over-communicative to our stakeholders.
Sorry, quick question here. So the scenario that you showed in the nursing, is it right now for pre-visit and during visit, or you have post-visit as well? Because you're talking about asynchronous communication, recordings and everything. Any thoughts there?
Yeah, and the image that he's referring to is the ambulatory clinic site. So for primary care, those are your typical clinics that you might see not in a hospital setting, right? So that's a very focused for a provider. And their use of the Dragon Copilot is different than the Dragon Copilot experience for nurses. They're not mobile dependent. Well, actually they are, but they have an ability to sort of sit down. They don't have a lot of the interruptions that are going on. But where we forecast the use of this technology can go through the longitudinally. Like I see this technology going from the home all the way to the home. Right now, we're looking at it from the segment of an acute admission through an inpatient hospitalization, and we're looking at it from a primary care visit. That's just two. Unanimously, we should be able to see this across the gamut of the experience, right?
Maybe just to add to what Darren said, so yes, what the product is being released for is for our acute care setting, right? Very specifically, we are basically focused on the med-surg nursing unit, and that is to make sure that we have the right AI accuracy, right? And then as part of our roadmap, we'll continue to expand to other service lines within the acute care setting as well.
And other health systems are talking about post-follow-up visit as well?
Yeah, I mean, when you think about the wearable market, everyone wants their wearables to connect, right? But when we think about the electronic health record, the EHR does not take in the Apple Watch data. It doesn't take in the Oura Ring. It doesn't do the Fitbit. And so when you think about the journey for all of us, like when you get sick, you're using those wearables to sort of pre-detect those so that you don't have to go to the hospital or don't have to go to the urgent care, right? But those systems are not that integrated yet. It's no different than it was in 1980 for some of these things, unfortunately. But I think with the advent of wearable technologies will come new innovations, and I think how we get these systems to speak to one another will definitely be a forecast. But I think the documentation of all of that information today will still be a manual manner for the near future.
I think you already highlighted one of the questions I had, which was care beyond the bedside, and what you might be exploring for next steps. But one of my other questions that I had was if the pilot explored, like language barriers or any scenario where a patient isn't actually able to speak, how Dragon Copilot might interact then.
Yeah, again, that comes down to the sort of the training and education piece. If actually, this is a really interesting thing. Microsoft really took the feedback that we provided where nurses were finding it very annoying that they would have to say, hey, what's your pain score? Mr. Jones, and you would say 8, I would have to repeat 8. And the technology, based on the feedback, they were able to incorporate the patient's voice into that experience now. I still have to validate that, but it's my responsibility to do that, but the technology can detect that. For accents, low volume, things in the rooms, those all come down to our training and education around putting controls. I would never do this for a patient that might be transitioning to comfort care, not appropriate. I wouldn't be doing this during teaching rounds, not appropriate. I might do this when it's a one-on-one with me and a patient in a room, and maybe they entrust me at that point. I mean, this is the part of that I think is the most inviting to nurses, is that this ability to not have to do so much documentation and just nurse is really the true North Star for us. How we get there, I think time will tell. I think the product is what we see today will even get better year over year. So
maybe if I can add to that, I think maybe the beauty of the product is that it supports multiple modes. We have nurses using it in a monologue, right? Literally like a natural language dictation, right? When they're on the go just by themselves. We have nurses using it for actual conversation, active conversation with a patient. And the way we have built the product is you can actually have different segments of that recording, so we call it like a mixed mode. So you can have maybe a conversation, and then maybe there were certain parts which were not clear, like the example that you took, and then the nurse could basically override those parts, right? And then what we have also built is something that we call like a dynamic guidance or a contextual guidance, that when the user kind of pauses the recording, the system immediately gives them feedback that, okay, here are the flow sheet rows that have been populated, and they can see which was picked up and which was not, and they can provide whatever is needed before they actually file it in the EHR system.
Great answer. Thank you.
You briefly mentioned AI governance, and I'm curious. I know Stanford has your health AI and RAISE frameworks, et cetera. But in the work that you're doing here, how have you dealt with either drift or escalations, overrides by clinicians, et cetera?
Well, can you say more about overrides? I'm not sure what you mean.
So if there is any kind of question about the clinical judgment, I know in this case it's documentation, but if there's question as they're going back and re-reviewing some of the notes or something like that, how have you dealt with those situations?
Yeah, I think this is a great question, and I think what it really cements this is, again, back to our training and education. We are not replacing nurses, and I think there's still this real sentiment that we have to surface for a lot of people, that you are still the clinician, you still have validation. All we're doing is changing the mechanism for which that information is getting into the record, but it's still on us to file that. We already do that today. For example, vital signs come and they are integrated right into our electronic health record. It's one of the few. But in that image that I showed you where there were like 15 different modalities into the room, I'm still doing those one by one. There's a pupilometer I'm doing that for, a ventilator that I'm doing that for, a urine output meter that I'm doing that for. That degree of accuracy on what I type and hit enter is no different than using that in ambient. I'm just changing the interface about how I'm doing that in more of a hands-free manner. So imagine saying urine output 30, chest tube output 50, serosanguinous, and that the patient ambulated 300 feet. In one sentence, the ambient is picking that up. I see it, I file it. That's a much different experience than doing that one, typing, doing that one, typing, doing that one. So from a legal perspective, we haven't seen any drift there. I think, in fact, we had one patient who was just like, what's taking you so long, Stanford, to get this going? And I think there are some parts of the hospital experience that are really just frustrating. One example is like a call light. A call light has not changed in over 50 years because the law for FDA requires that it be hardwired. There cannot be any interruptions for that. We edge into this when we're talking about ambient technologies because it will really change the dynamic of the room. And I think how we envision the new room or the future ecosystem, there's a lot of conversations about what technologies we want to put in there. And we don't want to make it feel like Best Buy. We want this to feel like a hospital room where it's healing and people can go home restful. And so if we can utilize these technologies to be able to do that, we should explore.
Thank you.
Yeah.
And actually, maybe I wanted to answer one other question that was asked by somebody in the audience, whether is this in production yet, right? So yes, the product was in what we call the preview, but all these customers and all these users were actually using it in production, right? So when I was talking about the 1,200 plus users and the 800K plus observations, yes, all that was in production and these were filed. It's just that we are now making it generally available for every other customer as well. And I think we are maybe now at time, so maybe you want to quickly ask your question and we can.
Yeah, sure. I think, the adoption rate in US is probably much better. Are there any guardrails? The regulatory need, especially in EU region, is quite different because we are also working on the similar lines and the challenges are quite different to increase the adoption rate. That was one. Maybe last one as well. Probably, it looks pretty cool in terms of the KPIs for doctors and nurses. Have you also measured some KPIs with respect to patients, more patient centricity? If you can share some light on that as well.
So maybe that's a slightly longer answer, but very shortly, we are launching this in the United States right now. Yes, our goal is to go international. I'm specifically talking about the Dragon Copilot experience for nurses, is to go international. But that is something that will come over a period of time and will follow the same process that you talked about because, yes, some of the regulations in EU and other places may be different. But maybe, looks like we are at time. Before everybody walks away, I also wanted to share with you some additional sessions related to healthcare or AI in healthcare that you may want to go to over the next couple of days in case there is interest. And Darren and I would stay here and then be available in case you have some other questions.
Thank you so much.